Hi, everybody. Thank you so much for inviting me here. Thanks to Dr. Ashraf and to Kate and to the conference organizers. And it's a delight to be here. And it's also tough to follow Dr. Jacob Slivka. So here we go. Let me do my necessary evils here. No direct conflict of interests. Lots of funding from different people or different organizations, including Merck and Pfizer. And also being a federal employee, much like Dr. Slivka, the opinions here are my own and not those of the VA, unless they like them, in which case they might, go with it. We'll see. So 3 learning objectives. We're going to talk about non-localizing signs and symptoms that may, but not necessarily, but may indicate infection in long-term care residents. We'll differentiate signs and symptoms of acute cystitis from other reasons for those symptoms. And then I'm going to introduce antibiotic use protocols for infections that are common among older adults, so that you'll have those as a resource. Okay, so you already know this about what a nursing home is and what nursing home residents receive in that setting. It's medical care, it's residential care, it's rehabilitation, it's spiritual care, and socialization. So not many hospitals, not like junior league organizations that are going to grow up one day to be in an acute care setting, but nursing homes where we care for our residents. Which means that when we try to apply antibiotic stewardship principles that were developed in acute care settings to long-term care, there are some significant challenges to that because things are just different. So let's talk through some of what goes on in long-term care. When we think about someone that has an infection, we want to think about things being yes or no, black or white, but that's not how our residents and our patients present. There's a spectrum. So people on the yellow side, not sick, do not give them antibiotics. They've got the sniffles, they've got something, we let them be. And there's people that we know, you are infected, I need to do something right now, I wish I thought of this 2 hours ago, we're gonna go and get things started. It's the orange people, the question mark people, that it's not so clear, what are we supposed to do? I'm not sure if you're infected, something's wrong, but I don't know if it's an infection. So, no infection, as an example. My mother bursts into tears every time I helped her put on her shoes. Do you think it might be a UTI? Of course it's not a UTI, it's a bunion. All right, Mrs. Smith has a temperature of 99.4 degrees and a hot red leg. That's cellulitis, let's get something going for her. Okay. But what about this guy? Mr. Jones has a terrible cough, shortness of breath, and leg edema. So is that a heart failure exacerbation? Or is that a heart failure exacerbation caused by pneumonia or COVID or influenza? Oh, I don't know either. So instead of jumping in with gorillacillin or pulling the big trigger and getting all the whistles going, what I suggest instead is that we engage in active monitoring, supportive care, diagnostic testing, which I know takes a while, but is still worth doing, and to keep thinking, which is often the hardest part for all of us, including me. It is much easier to fix it and forget it than it is to keep engaged. Okay, so to that end, I had the pleasure of working with a whole bunch of really smart people across ID and infection prevention world through SHEA. And we have a document that's about the reliability of non-localizing signs and symptoms as indicators of the presence of infection in nursing home residents. This is an update of the lobe criteria. There's so much more now that we don't have all the lobe criteria in one document, so we've got what I refer to as lobe number 1, and we're starting to, and then this virus happened, and then we kind of got sidetracked. We're working up again now to lobe number 2, so be patient. 5 years from now, we'll have something good to say. But let's talk about non-localizing signs and symptoms. So, when someone is sick, they have a fever a lot of the time. They may have, for respiratory infections, cough, sputum production, chest pain. They may have, for UTI-type issues, dysuria, frequency, urgency, hematuria, GI, nausea, vomiting, pain, diarrhea, and for skin problems or joint problems, erythema, swelling, pain. These are all localizing. They all go to except for fever, they point to a specific organ system. But we also have this idea that for older adults, that there's other things that can signify that someone might be sick. So it's poor appetite or anorexia, functional decline. Falls are a huge one, urinary incontinence, and a change in mental status. So here's the problem. Except for incontinence, and that's not entirely true even for that, these are all really not specific, and they can be all caused by any number of things. Like poor appetite, maybe the food's bad, maybe it's a lot of medications that they're taking, maybe they're constipated. And we can go through all these a little bit more, actually. So, right, here we go. Let's talk about unlikely signs and symptoms of infection. So poor appetite. There's lots of reasons for this, including decreased smell and taste, and dry mouth and poor dentition. Functional decline. There is an association of functional decline with infection, but it's an association, not a causation. So I can get pneumonia and have a functional decline, or I can have a functional decline and then get pneumonia. So you can't look to that and say, there's the problem. It just is. It's not specific. And then finally, there are falls. There's lots of reasons for falls, including weak muscles, poor balance, orthostatic hypotension, because we sometimes medicate people into normal blood pressure when they're sitting down or even laying down in bed, and that's the blood pressure that we're targeting, and then they stand up and then they come down real quick. Foot problems, vision and hearing problems, and then medication side effects. Let's talk about things that are indicative potentially of infection. So, change in mental status, that's the big one that I always hear about, and I have to not roll my eyes when I hear that. There's a lot of things that we think about with change in mental status. Acting whiffy, I don't count. Acting funny, I don't count. And there's kind of 4 buckets that we can think about for change in mental status. Depression, which is chronic, dementia, which is chronic, and these can be up and down a little bit. There's delirium, which really goes up and down, and hence to have an acute onset, but then it can go on for weeks to months. Not always, usually it resolves, but for some people, and it's the people that we all care for in long-term care, it can keep going. And that makes it appear chronic to us. And then finally there's a coma, and we should be able to figure that one out. So the litmus test that I use is someone having a change in behavior that I'm bothered by? They're acting out, they're using foul language, they're mad about their sheets, they don't like the food, they're just kind of being, oh, that person today. Or is it a change in the level of consciousness? Am I alarmed about this person? He's not only not acting like himself, he's acting like a sick person. I work at the VA, so most of my patients are men. Forgive me for the gender bias. So that change in level of consciousness, am I alarmed as a caregiver, as a clinician? That's when that's when I start getting going on the infection route. Okay, so delirium then, how do we assess it? There's the confusion assessment method, and even better, there's an app for that, which I love, and I use it, and I like it so much, and it's because I can put it on my phone, it's free, it's from Penn State, and I don't know if it is on Google, sorry. It is on Google and on Apple, it's free. And it looks at these 4 criteria: acute change in mental status with a fluctuating course and inattention, with either organized thinking or an altered level of consciousness. And the app walks you through the questions. And what I love about it is that I can do this on Monday morning, you can do it on Monday afternoon, you can do it on Tuesday morning, and we can start writing those results down in the chart and communicating and tracking what we're seeing. So it's reproducible, and it's not dependent on me knowing what the person is like in general, because we all know what that person is like in general. I love this. Okay, and I don't get anything from Penn State for talking about this. Causes and contributors to delirium. Yes, infection is among them. It is not number 1. There's many. So electrolyte imbalances, medications, oh my goodness, the medications. Not only what we give, because I think we're all really good about recognizing the Beers criteria now and not giving anticholinergics and similar medications. The withdrawal is something that I don't always think about. So are they no longer on the benzos or the alcohol that they were on before they came in? Have the SSRIs been changed? Were they given a whole lot of narcotics in the acute care setting and some sedation and a little bit of this, and now all that's going away all at once because we're good in long-term care about not giving these things, and are we, making that little brain so imbalanced now? Dehydration, pain, constipation, urinary retention can really make someone that already has dementia very fidgety. Immobility from catheters and lines, sleep interruptions and noise, and then impaired vision and hearing. It is so hard to speak like you're a normal person if you can't hear what anyone's saying to you. And so you may come across as being as being a little odd if someone's not like right here, or you don't have your hearing aids in. Okay, so delirium, check when it's real. Fever, yes, of course a fever is a sign of infection. And it's how do we measure it in long-term care that we have to be, I think, a little bit more thoughtful of. I still teach this to my ID fellows. A fever is not a yes-no thing. It's not greater than or less than 100.4, especially for our older adults. We have to see where they are and recognize that as people get older, they get colder. So a single temperature, any one temperature over 100 degrees Fahrenheit, fever. Start thinking. Repeated temperatures of 99, like it's been going on for 2 or 3 days or a week, and they're just kind of bumping along, that's a fever. They're trying, our older adults are trying so hard to make the cytokines so that they can show us that they're inflamed, and this is the best they can do. So we have to meet them where they are with their temperature and have a lower threshold. And then my favorite is any increase in temperature of greater than 2 degrees Fahrenheit or 1.1 degrees Celsius over the resident's baseline non-illness temperature. That's a long way of me to show you, we'll go through a case and then show you a graph. So we've got an 82-year-old resident with dementia, congestive heart failure, she's on aspiration precautions, and the nurse aide noticed a new cough. So, does she have a fever? I don't know. She's 98.7. She's got 97 beats per minute for her heart rate, so she's maybe a little tacky. Blood pressure is okay, and she's 93% on room air. When I go back and look at her temperature curve, yeah, she's got a fever, because that's a big jump. And even if it doesn't get us up to that 2-degree threshold Fahrenheit, that's still a big jump for a lady that usually runs, if you kind of draw a line across there, she's running in the 96.2 range as her baseline. So this is kind of a big deal where we're seeing her head now. So this I would definitely count as a fever and start to think about what we should do next for her. Hypothermia is also a sign or symptom of infection that seems to be specific to getting us, towards making a diagnosis. By the time I see somebody that has true hypothermia where there's been a real change, we already know that they're sick and they're no longer in the long-term care setting. They've already been transferred to acute care if they're not already in the ICU. If this is the only thing that you're seeing that's got you, that's getting us concerned about infection, I suspect that we're missing something, or it's not really an infection, and you might need to get a different thermometer. So it's not that this isn't real, it's usually an extreme and a down the road sign. And then finally, hypotension. We went back and forth on this a whole bunch as we talked about it. And so we wound up with kind of, and I wish we didn't, but here we are. There's 2 thresholds. The one that was preferred was a systolic of less than 90 millimeters of mercury. But we can also go with less than 100. Or you can do a decrease in their baseline, or a mean arterial pressure of 60 to 70. So the back and forth here was really about trying to keep things simple, but also recognizing that a lot of our nursing home residents have a systolic blood pressure that's already below 120. And so on occasion, if they get down to 100, it doesn't mean that there's something horrible going on. It just means that they're low at the moment that you're checking the blood pressure. So this is not a case for, pull the alarm bell. This is a case for let's keep going and see what else is going on, if this is the only thing that you see. Hyperglycemia. There is a connection between hyperglycemia and acute illness, including infection. However, there aren't really a lot in the way of thresholds or specific values to look at for changes that we say, that's clearly an infection. Because there's a lot of other reasons, like they might come in the box by the dozen, that people have a high blood sugar. And so we can't really rely on this in and of itself. It's one of those things I think we go back and look at and say, oh yeah, look, he's been hyperglycemic for the last week and a half, and now all at once we've got this thing happening. So the summary here: possible signs of infection: fever, real delirium, hypotension, hypothermia, hyperglycemia. Unlikely signs of infection: poor appetite, change in mental status, falls, and functional decline. Okay. All right, so let's move on now to urine. So we all know from Loeb criteria and the McGear criteria and the revised McGear criteria and all sorts of other fantastic work, that the signs and symptoms of a urinary tract infection for older adults, especially in long-term care, dysuria alone is enough. Or they can have fever and urgency, or fever and flank pain or suprapubic pain, fever and new worsening incontinence, fever and gross hematuria, and then fever with shaking chills. So if it walks like a duck and it talks like a duck, it's probably a duck. Unfortunately, it seems like there's other things that happen in long-term care a lot. So sometimes it's not really dysuria, but that's what we talk people into. It feels funny when I pee. Oh, does it hurt to pee? Yeah. And then that gets transcribed as dysuria into the medical record, and then all at once there's a UTI. But it really might be, I have a yeast infection and it feels funny when I pee, or I've got a prostate issue and it feels funny when I pee. Urinary retention, not ever an indication of a urinary infection. I've had more people than I care to tell me that they have treated urinary retention with ciprofloxacin and things get better. I don't know what happened there, but please don't do that ever. Okay, change in mental status, behavior, or function, that's clearly something else, we discussed that. Dark or funny smelling urine. Why are people so interested in smelling somebody else's pee? That's gross. It's always darker when it's in the bottle or in the hat, because all of us are used to seeing it in the toilet where it's yellow, but then you put it somewhere where there's not a whole bunch of water in the toilet to dilute it down, and it looks a lot dark, and I know it can look darker in the urinal. What? So just tell me, shout it out. If someone has dark urine, what's going on? Yeah, they're dehydrated. We've got to give them some water. There you go. You guys don't need me up here. You already know all this. All right. Falls are not an indication of an infection. Falls is an indication of a fall. That's the problem. And yes, there might be upstream reasons for this, but address the fall first and then go back and figure out what it is, and don't check a urine for crying out loud. And then family or resident request. We have done so well for years and years and years of training people. Well, it might be a urine. We have to retrain them. We have to work on this. I continue to work on this, and I know all of you will too, because I'm going to give you some feeding or some feeders for that. So here we are in long-term care, and I feel like we have to be a little bit more thoughtful about what we're calling signs and symptoms of a UTI versus putting labels on things. It might be urgency, or it might be that the poor guy has gout and can't get to the bathroom in time because his foot hurts so much. So it's not even incontinence at that point. It's just poor mobility. Does not mean a UTI. Okay, so some things to think about. Dysuria might be a yeast infection, might be a big fat prostate, might be lower urinary tract infection, lower urinary tract syndrome, or LUT, which is so much easier to say. It might be urethral stricture. Lots of stuff can be going on here. The first time someone says I have dysuria, it's very reasonable to try to course a Bactrim or the nitrofurantoin. But if it happens again a week later, it's not a new infection. It's something else, and that's where we go down this rabbit pathway, not the duck pathway. So other things, flank and suprapubic pain might be spinal issues, muscle spasms, shingles, GI issues like they're really backed up, renal stones. We talked about incontinence can be a mobility issue, or neurogenic bladder, or pelvic floor weakness. Gross hematuria can actually be prostate issues, and there's often a lot of instrumentation or a Foley catheter that got, pulled. And And I actually did this to myself once. I walked into a patient's room and I was like, whoa, that's Kool-Aid coming out. What's going on? And the nurse at the bedside said, oh, he's on rifampin. I was like, oh yeah, I started that. All right. And then finally, if someone has a fever or shaking chills, it might be a urine, but if that's where the thinking begins and ends, chances are you're missing out on the chance to find out what's really wrong with the person, because by the time you get fever and shaking chills from a urinary issue, it should have already been announced, and it's pretty far gone at that point. So think about things like gallbladder, pneumonia, cellulitis, bacteremia. Okay. Active monitoring. I love this. This came from David Nace and Chris Cernich and Paul Drinka. This has had many names over the years, but I like active monitoring the best because it's the idea that we're doing something. We're not just watching them. We're actually doing something. And so this does the two things. It gives the staff a very clear set of things to look for, some criteria. Do this, do this, do this. Get the vitals. And then, and get the fluids, and then close the loop. Call the provider back. Let the person know. So if something happens quickly, then tell me sooner. But if it's 24 hours later and things seem to be back to normal, let them know that too. Pass it on so that we know what's happening. And this loop closing is actually very helpful, and it lets people know we are doing something. I hear you. There's something that's a problem. Let's address it together, and we'll invoke this. And if it turns out that after 6 hours, that fever of 99 is now up to 101, and you're like, oh yeah, I need to act on this, then you've got the antibiotic in your back pocket. It's not like you're not committed to this. You can change course. That's what it's there for. It's not a one-time decision. Okay, so with that, let me now move into the idea of some antibiotic use protocols. This was work that I was so privileged to do with AHRQ, Johns Hopkins, and the NORC at the University of Chicago. It was a huge project, and we did an intervention in long-term care. There was also an arm for acute care and ambulatory care. And the whole idea here was to create the culture of safety to help support antimicrobial stewardship, and that helping everyone to understand it's a patient safety issue. But now that I've heard the honeybee story, I think that's where I need to go, because that's a lot cuter and makes more sense. I think there's some other stuff that we talked about. This intervention worked. This was a quality improvement intervention. We were remarkably successful in enrolling 250 plus nursing homes and keeping most of them. The CMS regulations that were coming out that were imposing stewardship in long-term care may have had a little bit to do with that, but it was really amazing. So we found that there was a specific reduction in the number of antibiotic starts, especially for fluoroquinolones. We also had a reduction in the antibiotic days of therapy, again around fluoroquinolones, and a huge reduction, or a pretty good reduction, I shouldn't say huge, but a pretty good one for urine cultures collected as well. We did not see a difference on C. diff lab ID events. Nonetheless, it worked. It was really fun. So let me show you some of the fruits of our labors there. So the first one is the 4 moments of antibiotic decision making. This is supposed to parallel the 5 moments of hand hygiene, just as a riff off of that. So the first one is to make the diagnosis. Where I practiced before going to the VA Pittsburgh, there were times when I would get a call from one NP in particular, and she'd tell me, well, I'm not sure if he's got a urinary tract infection or a pneumonia. Okay, when did this start? A couple days ago. Oh boy, okay. Like if it's Wednesday and you've known about this since Monday, you should be able to figure it out by like something that tells you UTI from pneumonia. They're not connected at all. So make the diagnosis first. Get cultures and start empiric therapy for people that are acutely ill. And think about the duration of therapy. And this needs to happen, especially in long-term care, at the outset of therapy, because it might be that you call the doc on a Monday and you get the culture back on a Thursday, and they want to keep going for 2 weeks, but if there's a drug bug mismatch, or 2 weeks is just too long, which it is, you probably could stop the antibiotic on Friday. And so what I would suggest, instead of going for long courses, Try to work with your practitioners about going to a 5 to 7 day course for most things, and then if someone is still sick, you can extend it and then rethink about what's going on there. And then number 4 is stop, narrow, and change to oral agents when you can. So there are a lovely array of antibiotic use protocols on the website. They are almost all one-pagers. I think they're almost all on one side, actually, of one page, and the references are on the back. So there's some for asymptomatic bacteriuria, for suspected UTI, for COPD, for aspiration events, for bacterial pneumonia, for influenza. We did not have one for COVID, though I think we kind of allude to COVID for viral infections. There's cellulitis and C. diff. So it's all there. There's diagnosis, there's signs and symptoms, diagnostic tests, what to treat with and how long to treat them for, and the references. These are all free. Most of them are on Word documents, so you can modify it. You can take off the AHRQ label and put your own label on there. Go with God, make it work, take them, please use them. I actually turn to them a lot, which is interesting because I help write them, but I can't keep it all in my head. Okay, and then here's some of the other resources that are on that site besides the antibiotic use protocols. There are, and I don't expect you to read this, I just want to give you some examples of the kind of information that's there. So there's, looking at someone that may have a suspected urinary tract infection in long-term care. People that do have that do not have a catheter, or that do, or that can't express themselves because they're nonverbal or don't always make a lot of sense when they speak. So there's some very specific criteria there, and then what to do, and then when not to send that urinalysis and culture. We also talk about urine culture collection and put a lot of emphasis on that. Because if you don't, I truly believe it's harder actually to get a good urine culture than it is to get a good blood culture. Because it's just, you can't scrub the way that you can here and get a clean sample. So that becomes an issue as well. Here's an example of the one-pager. It looks like we got, oh no, that's actually still one-pager. Does it show up better? All right. I don't know what happened at the top of that second one. I can't even guess at what it is because I can't read it either. But anyway, there's 2 one-pagers for you. There's also a lot of information about how to talk with family members, and this applies to people that might be part of any type of family, including the CNAs that work in your nursing home as part of your family. So my father's not himself today. His urine is dark and it smells bad. Do you think he has a UTI? And here's some language that you can offer back to, I hear you. Dark and foul-smelling urine is usually not enough to decide that someone has a UTI. Here is what we looked for, and these are the things that we're going to try. Your father might just be dehydrated. Let's give him some fluids, which you guys already told me. Well, would you just check his urine just to be sure? And we all have these people that we work with that want to do that. And so this is where the active monitoring comes in. You know what? I like the idea of checking a urine before we do that, because I don't want to go down the pathway of then writing for an antibiotic if we don't need to. Let's instead do this. And so you're saying, good idea. I'm not saying no, but first we're going to pivot and go over here and do this thing instead. So we are acting together, and we're not just going to respond with an antibiotic. So no knee-jerking. Okay. Skin and soft tissue infections, and kind of what to think through for purulent and non-purulent infections. Bilateral red legs are not cellulitis. Bilateral red legs are venostasis or chronic skin changes. Yeah, and you guys know this too. The residents I work with do not know this at all. Okay, so finally, taking another shift, I'm now shifting into active recruitment phase. We have currently, and has just started yesterday, program just began yesterday. There's an 18-month skin care and MDRO prevention program sponsored by the same group, the AHRQ work that I just showed you. So it's actually myself, Morgan Katz, and this kind of the same over-organization. So now we've gone from antibiotic stewardship, we're going to focus on infection prevention in long-term care. The program itself, formally is supposed to be about MRSA, but that's clearly not what we need to focus on in long-term care. We need to focus on all the MDROs because it's, we don't do surveillance in long-term care. We have to know that we're doing something about all the bad bugs. So we're just kind of keeping that broad. The thing that we're focusing on as we do the teaching for this and share the information is about good skin care, because as Dr. Jacob Slifka mentioned, it's the wounds that are a huge problem. So if we can prevent wounds or recognize them and address them early before things get bad, this is going to help our long-term care residents not become colonized or infected with some of those MDROs or have to go on to enhanced barrier precautions. We'll emphasize stewardship as well as environmental cleaning. The program began yesterday. It's 18 months. Open enrollment is still happening. We would love to have you. It is free. Lots of continuing education credits for, there's nurse education units, there's infection preventionist units of some sort, and I forget what those are called, but we have them. And there's actual credits for the administrators as well, and CME for other providers. You get to talk to me, if you want, and other people that are much smarter and maybe have an interesting and different perspective than I do. And there's a registration. Probably the easiest thing to do is send an email, MRSA-prevention@norc.org. I'm very excited about this program. I think it's going to do a lot of good. I think we're hitting this at the right time now that, as we've already talked about, people are really good now at infection prevention, at least the idea of it in long-term care with lots of supplies. One of the really neat things that we're doing for this is that we're calling them teachable moments. These are one-pagers that the IP or the nurse educator or the DON or whomever can hand out during a monthly meeting, a morning huddle, whatever it is. Less than 5 minutes, very simple. Here's a case, here's a question, and it's a knowledge question. These are not gotcha questions. These are mostly going to be all the above in terms of the answer that people are learning as they're looking over those questions. The answers and some explanation on the back, all very light and easy. Each of them also comes with a log. The topic, a little bit of the information, and then name, sign, date. Everyone who gets a handout names or writes their name and signs and dates it. That becomes the education log. So when the state surveyors come around, you can say, look, we are doing continuing education on infection prevention, and here are all the records that we have to show. These may look, and I think they are very basic. We are trying to emphasize the bathing especially so that we can teach people who are new to long-term care, because that's most of the workforce at this point, how to take care of older adults. This is in part to try to help rebuild some of the institutional memory that I think that we've lost from COVID, so that, and the nice thing about these is they can be reused or adapted, so that when the workforce turns over in a year and we're talking to someone who's been there for 2 years longer, or 2 weeks longer than I have as the person of experience, we have things like this to fall back on for knowledge as well. And with that, I will end with a nursing home haiku. And while you're counting out syllables, I'll be happy to take questions as well. Thank you so much.